Good evening. Welcome to VDC Diagnostic Education webinar series. I am Dr. Kishore LT, Director of Radiology Education and Training, Vijaya Diagnostic Center. We conduct these clinical radiology webinars regularly. The purpose is to learn something from our clinical colleagues. At the same time, show them what's new in radiology and the newer applications and the newer innovations which are happening in radiology. So with this interaction, what happens is the patients are eventually benefited. So that's the main philosophy of conducting these webinars. So in this webinar series, today we have chosen a very interesting topic. It is called MINOCA, myocardial infarction with no obstruction of coronary arteries. And Deepak, just for your information, this is a new term. When we were young like you, this term was not existing. We used to have the terms like Prinzmetal angina and cardiac X syndrome and coronary spasm, etc., etc. So this is a new terminology, and obviously with the advancement in the technology, we have a lot of new pathophysiological facts which are being revealed in last few years. So for discussing this topic, I have two very eminent faculty. First, I would like to introduce Dr. M. Srinivasa. He is the chief guest of today. He is a very senior cardiologist of more than 30 years of experience. He has done his MBBS in 1981, MD Internal Medicine in 86. During this period, he has got multiple distinctions and gold medals. Eventually, he has done his DM Cardiology in 1989, and he has been associated with NIMS, Medicity and Care Hospital for a long time. And currently, he is the head of the Department of Cardiology and Interventional Cardiologist in Apollo Hospital, Hyderabad. And he is an avid academician. He has mentored and guided more than 60 fellows and made them interventional cardiologists. And he is actively associated with a lot of research activities. I can see that he's associated with at least 10 research projects and clinical studies. And a number of his publications and presentations are, I think, too many. If I want to read all these things, I will need half an hour. So we can't afford all those things. We'll stop here as far as Srinivasa is concerned. And then to discuss this topic, we have a very young and dynamic radiologist, Dr. Deepak. He's the consultant radiologist with Vijaya Diagnostic for the last 6 years. He's MD, DNB, diploma, European diploma, FRCR, whatnot in radiology. And cardiovascular radiology is his primary area of interest. So I think we'll go ahead with the discussion. First, I would request Dr. Srinivasa to give us clinical perspective regarding this terminology, MINOCA and INOCA. Srinivasa, over to you, please.
Good afternoon to everyone, and thank you, Kishore, for introducing me to the audience today and to the participants. And I'm really very glad to be associated with you, with eminent radiologists like you and Dr. Deepak. And it's a great pleasure to be participating in this seminar. And I'll always, as Dr. Kishore was saying, it's always like learning never stops in life, and we keep on learning, keep on learning. The day when we think that we have learned enough, that's the end of our learning, that's the end of our career. So we now carry medical career. We need to keep learning, and keep teaching others also. So we keep learning from your juniors, keep learning from seniors, we keep learning from colleagues, everyone. So as this topic actually, it sounds very interesting, the MINOCA and INOCA, that's where the term which is really this recent past, about 8 years from now, it's been coined, and then since then it's being actually applied in the clinical practice as well. As we know, microinfarction results because of the obstruction in the coronary artery, a complete obstruction of the artery or subtotal obstruction of the artery. But then there are about 8 to 10% of such kind of microinfarctions which we see do not have an obstruction, obstruction which can account for this kind of infarction. So because of this, the there is a new term that is coined as MINOCA, which is myocardial infarction with normal coronary arteries without an obstruction. So this is not one entity, it is a conglomeration of several entities. It could be being produced because of some pathophysiology in the coronary artery itself or in the myocardium or systemic as well. So now, yes, it can be because of the coronaries in the sense the coronaries can get into spasm and produce myocardial infarction, and then when you do cath, then the spasm disappears, you find absolute normal coronaries. There is spontaneous dissection of the arteries also. It generally is seen in women, especially in the perinatal period, which also can cause a MI. And it also can cause, then also there's what is called a systemic emboli. It can go into coronaries and then get lodged in the microcirculation. Another MI can produce. And sometimes there could be plaques which are actually can erode themselves and cause platelet emboli, and also can spot a rupture of the plaque, can produce MI by virtue of embolizations and material from that area to distal areas, which results in myocardial infarction. Apart from that, we also have certain myocardial factors as well. For example, the microcirculation. The microcirculation can be defective. It can act, microcirculation is very dynamic circulation. It can actually be influenced by some several systemic factors. For example, extreme psychological stress, extreme metabolic stress can also lead to imbalance or alteration in microcirculation, which can give rise to this, dysfunction of myocardium. And this is what we see in Takotsubo syndrome, which is not known as a, when I started practicing my cardiology, we didn't know about this. It took nearly 10 years from us to know that this entity is described later on. So we were actually treating these people, but without getting to know what is really the pathology. Then we also have myocarditis, which actually produced because of some either infection or maybe some systemic causes, which also can produce elevation of enzymes, cardiac enzymes, troponins, and etc. And sometimes they can also have changes in the ECG, mimicking the mind. So all these things are. Now, today we are actually here to actually discuss how best we can actually recognize this, how best we can treat it. Why are we actually trying to, trying to actually so much emphasis on this? Is because people who got MINOCA, they have a better prognosis than those people who obstructive disease is causing myocardial infarction. In fact, people who got MINOCA have a lesser amount of, systemic risk factors we can produce myocardial infarction. The prognosis also is better than the, ischemic heart disease because of the coronary arteries which has got atherosclerosis. In fact, even the treatment pattern also differs in the sense those people who got MINOCA tend to have more bleeding with the aggressive treatment of the antiplatelet agents. So compared to a coronary disease producing myocardial infarction. So they're all different things. But what is important is how best we can actually get into a diagnosis, how best we can ask, we can take the help of radiologists to try to help in diagnosing this, because imaging is a cornerstone in trying to recognize this entity. And then you need to have imaging of a good quality, especially after invent of MRI. We have really become more aware of these situations where we come across with myocardial infarction with normal causes. And that's where Dr. Deepak is going to tell us today, and then he's going to give his experience, and along with Dr. Kishore, who is going to guide this seminar. Thank you.
Thanks, Srinivas. So, may I request Dr. Deepak to start his presentation and give us new insights about this MINOCA and INOCA, please.
Surely, sir. Thank you. So, hi and good evening, everybody. I'm Dr. Deepak. I'm a consultant radiologist at Vijaya Diagnostic Center. And firstly, I would like to thank Dr. Kishore sir for the kind introduction. And also, I would like to thank Dr. Srinivasa sir for the wonderful insights, what is given the clinical perspective into this elusive diagnosis. So the reason we have chosen MINOCA and INOCA as today's topic is because we are increasingly seeing requests from clinicians to help arrive at a diagnosis. And let me give you a perspective, because this is a new terminology like we've already discussed now. The first usage of this term was way back in 2013, but since then That was the first paper which was published about MINOCA in 2013. So since then, almost 200 papers have been published on this topic. So let me first tell you that this is a topic where there are some fundamental gaps in our knowledge at this point, and this topic requires more and more research and experimental studies and research to bridge these gaps and make our understanding on this topic more comprehensive. Having said that, I think it's appropriate for me to straight away go into the topic. I have no relevant disclosures, and there has been fair usage of copyright material in this presentation. So, what does MINOCA and INOCA stand for? Myocardial infarction with non-obstructive coronary arteries and ischemia with non-obstructive coronary arteries. So, as the name implies, there is no significant obstruction to coronary arteries. So, it is predominantly a microvascular disease or microvascular dysfunction. We have to remember that this is not a single disease as such, but it is a heterogeneous group of disorders. Now let's look at the prevalence of this particular entities, MINOCA and INOCA. They account for almost 5 to 15% of patients with acute myocardial infarction, which is a big number, it's significant. And it is more common in females, and it's slightly younger age group than the obstructive coronary artery disease patients. So this is a definitely unique perspective about this diagnosis. So how is this different from obstructive coronary artery disease? The patients with MINOCA have a different cardiovascular risk profile. That is, they tend to have less risk factors like hyperlipidemia and diabetes, but somehow hypertension appears to be a predominant risk factor for MINOCA. And MINOCA patients generally report less angina prior to an acute event, and the prognosis is slightly more favorable than the obstructive coronary artery disease. However, this is an entity which is not to be taken lightly. Okay, and the occurrence of recurrent infarction and the need for urgent revascularization is generally less than in patients with obstructive coronary artery disease. So there are certain differences, fundamental differences in both diagnosis aspect and management in patients with MINOCA. So what is the definition? Three important things of MINOCA is that the first thing is MINOCA is defined by the evidence of MI according to the fourth universal definition of MI, which came out in 2018. That is the latest definition. Secondly, there should not be any significant coronary artery stenosis, as the name implies. So there usually should be either 0 or less than 50% luminal stenosis in any major epicardial coronary arteries. The third important thing is there should be no clinically overt specific cause to account for the acute presentation. So what are the causes? Like sepsis, pulmonary embolism, myocarditis, tachyarrhythmias, hypertension, so on and so forth. So let us briefly look at the etiologies of MINOCA. What are the causes of MINOCA? It can be due to a coronary plaque rupture or erosion. It can be due to coronary artery spasm, which is epicardial or microvascular. It can be due to a distal coronary artery embolism or thrombosis. It can be due to a coronary artery dissection, spontaneous coronary artery dissection, like Dr. Srinivasa has rightly said. It can also be due to unusual causes like Takotsubo syndrome or myocarditis. Now, these pictures show us, the different graphic representation of causes for myocardial injury. If you actually see that I in the definition I mentioned that there is no definite cause of myocarditis in MINOCA, but when I said about the causes in etiologies, I said myocarditis could be one of the causes of MINOCA. So that answer, that clarity we can get in this particular image, where A shows the theoretical causes of myocardial injury, where they're clearly separate ischemic and non-ischemic causes. But in practically, we don't see that clear distinction, and there's slight overlap between ischemic and non-ischemic cause of myocardial injury, and therefore myocarditis itself can be one of the background causes of MINOCA. Now, this graphic shows us how the relation is between ST elevation MI, non-ST elevation MI, and type 1 and type 2 MIs. we can clearly see that MINOCA is predominantly, a type of non-ST elevation MI, and more so in type 1 MI is what we see in most of the MINOCA patients. So what is the relevance of MINOCA? So a patient who is presenting with chest pain or acute coronary syndrome, the cardiologist may do an angiogram, and if we don't see any significant uh, stenosis, that should not falsely reassure the clinician. So that is the main relevance here, and it definitely needs further testing aimed at identifying the underlying cause for the clinical presentation and guide the appropriate clinical management. So that is the relevance of this particular disease entity. So when I said further testing, what are the further testings which are available most commonly to arrive at a diagnosis of MINOCA? So there are invasive and non-invasive testings. So the invasive part are optical coherence tomography, intravascular ultrasound, and cardiac MRI. In these three tests, the optical coherence tomography and IVUS, the first two, are rather invasive testing, whereas the cardiac MRI is a non-invasive testing to arrive at this diagnosis. So optical coherence tomography uses a fiber just like an angiogram, but instead of sound, we use light, infrared light, to clearly visualize the diseased coronary arteries, the endothelium, and the various layers of the major arteries. If you can see in this picture, the one labeled as B, this is an image of optical coherence tomography where you can clearly see a plaque rupture. This patient actually had a normal coronary angiogram with no significant stenosis. But when the OCT was done, there was a definite plaque rupture, and that was the culprit lesion. And another patient who also had acute coronary syndrome, a coronary angiogram was reportedly normal, and intravascular ultrasound was done. And that is showing a dissection here. You can clearly see separation of the layers. So these two tests are definitely important in diagnosing MINOCA, but there is one disadvantage, is that it could be, invasive testing, and it's not readily available everywhere. So we are left with cardiac MRI, which is a non-invasive testing and generally more available than OCT and intravascular ultrasound. So today's talk, we are going to focus a little more about how cardiac MRI can help us arrive at a diagnosis of MINOCA. So let us see what the role of cardiac MRI is. Both the European Society of Cardiology and the American Heart Association have recognized the importance of cardiac MRI in the workup of patients with MINOCA. And in particular, according to the recent guidelines of 2020, the European Society of Cardiology has indicated and recommended MINOCA in all the patients of MINOCA with no obvious cause. So that is quite important, considering that MRI plays a vital role in arriving at a diagnosis. So what are the uses? What is the advantages of having doing an MRI? It is definitely non-invasive, like we discussed, and it gives us a comprehensive imaging of the heart structure and its function. We can also do tissue characterization. We can know what type of tissue, what the myocardium is diseased or not, and we can characterize the tissue. And we can also differentiate between reversible and irreversible tissue damage, and we can differentiate between actually true MINOCA and MINOCA mimics some disease entities which can mimic MINOCA, right? So what is the timing of MRI in suspected case of MINOCA? The ideal timing would be within 2 weeks of the acute coronary syndrome. So the diagnostic yield is quite high, up to 84% in the first 2 weeks. As the time progresses, the changes in MRI would disappear. So if you image a patient with suspected MINOCA in, let us say, after a month, then you probably will not find much of changes, because all the edema and the disease in the myocardium would have probably resolved. So what are we looking for in cardiac MRI when we suspecting MINOCA? We generally look for something called as late gadolinium enhancement. That is the enhancement what we look for, which can differentiate between ischemic and non-ischemic pattern of myocardial injury. And there is also advanced imaging in cardiac MRI, which is parametric imaging, which is basically T1 and T2 mapping. That also helps in aiding the diagnosis of MINOCA and further characterizing the cardiac tissue damage. Now, when I say late gadolinium enhancement, we can see different patterns of enhancement in the cardiac muscle. These different patterns help us to narrow down the diagnosis and give a probable cause for the diagnosis. So we can see different patterns like transmural, subendocardial pattern of enhancement, and also epicardial. And in MINOCA, we usually typically see the ischemic pattern of enhancement, which is transmural and subendocardial pattern of enhancement. And we also see myocardial edema in the acute phase, that is the initial weeks following the insult. So this is a graphic representation which shows us what are the types of enhancement which we can see in cardiac MRI. The first two patterns, this is the transmural pattern and this is the subendocardial late gadolinium enhancement pattern. These two patterns are generally quite distinct and specific for an ischemic damage of myocardium. The other patterns can be seen in infiltrative heart conditions and various other systemic causes. So let us see some cases what we have seen in Vijaya Diagnostic Center. This is a patient who had, is a young patient rather, he had an acute coronary syndrome. Clinically, they were suspecting MINOCA with elevated cardiac enzymes. You can see here more than 3,000, and the echo was reportedly normal. Patient was discharged after a diagnosis of MINOCA, and he was sent to us for a cardiac MRI. So we have done a cardiac MRI, and what you can see is edematous changes. This is edema. What we are talking about is the edematous changes in the lateral segments of the left ventricular myocardium. And we've also done a post perfusion study. We didn't see any definite perfusion defect in the rest imaging. And then we did a late gadolinium enhancement. And this is the typical transmural pattern of enhancement, what I was talking about. This is typically a transmural pattern, which is seen in the basal region, in the basal region and mid cavity region in the inferior segments. This patient had a normal coronary angiogram. So this is one such patient with MINOCA where there was a normal angiogram and MRI is abnormal, showing MINOCA kind of appearance. So this is another patient. This is from a journal where patient had acute coronary syndrome. Coronary angiogram was normal, and again we can see a transmural pattern of enhancement in the apical region and apex of the LV myocardium, left ventricular myocardium, along with the tissue edema. This is another patient. Similarly, he had acute coronary artery syndrome, and then the angiogram was normal. And then we again can see the transmural pattern of enhancement and edema. And also we can see the changes in T1 values of the myocardium. So this is the parametric imaging I was talking about. So definitely we can first differentiate between whether it's actually MINOCA or some other disease. And if it's MINOCA, we can localize what territory it is in and what is the pattern of enhancement. Now, like I said, myocarditis is also one of the causes of MINOCA. So this is another patient we had, and this patient had dilated cardiomyopathy with left ventricular dysfunction. As we can see, patient also had CVA with cardioembolic stroke. So he was sent for cardiac imaging, and we could see a epicardial pattern of enhancement. This is epicardial pattern of enhancement and epicardial edema. We can clearly see this in even the next slide. See the epicardial pattern of enhancement. This is also again a very suggestive of myocarditis, myopericarditis, causing MINOCA in this young patient who had a normal coronary angiogram. You can see that the functional aspect also, there is all decreased left ventricular indexed values, which we also can get in cardiac MRI. So like I said, we can get a comprehensive idea of the cardiac anatomy and also the cardiac function in cardiac MRI. This is another patient. This is an image from a journal where you can see the myocardial, the epicardial edema and the epicardial late gadolinium enhancement and alteration in the parametric imaging values, native cardiac values. This is also a typical enhancement pattern and edema of myocarditis causing MINOCA. Now, we have seen two unusual names, unusual name, that is Takotsubo myocarditis or Takotsubo cardiomyopathy. Let me tell you a bit of trivia here. Takotsubo is a Japanese word. It really means a bag which is used to catch octopus. So the heart, actually, the deceased heart in this condition resembles that bag. So that's why the name of Takotsubo cardiomyopathy. So what happens in this is it is more common in elderly women, and it is also called as a stress-related or apical ballooning cardiomyopathy, where there will be a normal coronary angiogram probably, and the typical appearance of ballooning of heart can be there, most commonly at the apex, and interestingly, that will not show any late gadolinium enhancement. So this is one condition of MINOCA which will not show any late gadolinium enhancement, but there is a typical appearance of apical ballooning of the heart, what we can see here in the cardiac MRI. And also the parametric imaging, we can see the alteration in T1 and T2 values in that particular segment of diseased myocardium. So this is again an unusual cause, but a very distinct entity called as Takotsubo cardiomyopathy, which is also one of the causes of MINOCA. So if I have to summarize, we can say that MINOCA is definitely emerging diagnosis. We are seeing more and more requests from the clinicians. Our understanding is also, still improving, and we are trying to get really to the bottom of what exactly the multiple factors which can cause this diagnosis. And what is important is when there is a diagnosis of MINOCA, working diagnosis of MINOCA, it definitely needs further evaluation to exclude other potential causes. And like we have seen in the past few slides, cardiac MRI has a very important role in the diagnosis, and it is definitely being more commonly used in aiding the diagnosis of MINOCA. So these are my references for this talk today, and I thank you all for the patient listening. Thank you once again.
Yeah, Dr. Deepak, thank you very much for giving us this insight and telling us the importance of cardiac MRI and how it will differentiate between the myocardial ischemic changes versus non-ischemic changes like myocarditis, etc. So that way we can help our cardiology colleagues in deciding about the management part of it. Before I open the topic for question answers and discussion, I have one question. Tell me, what is the connection between MINOCA and sudden cardiac death?
Yes, sir. So MINOCA, we have seen in the one of the slides that there are multiple causes and multiple factors in which can cause MINOCA, and 2 or 3 different factors can work at the same time to cause the myocardial injury. Generally speaking, like Dr. Srinivasa has already told us, that MINOCA generally has slightly better prognosis than obstructive coronary artery disease. So the chances of a patient having sudden cardiac death due to MINOCA is generally much lesser than the classical obstructive coronary artery disease as such. So one can expect that the chances of sudden cardiac death are probably lesser in MINOCA than obstructive coronary artery disease. Yes, sir.
Right. Okay, so now Dr. Srinivas, you heard Dr. Deepak, and any comments, any questions, any remarks?
First of all, let me congratulate Dr. Deepak for the excellent presentation. There's very
Thank
nice presentation today, and then nice, images are shown, and then also you have shown the audience and how important it is imaging. And many times when we actually send these patients for cardiac MRI, when we find a menocardiac situation, we want to also do some intravascular imaging also. We do a OCT, because OCT, see, when you're looking at coronary angiogram, you're just looking at the image from outside. We don't know what's happening inside. So in order to understand what happened inside, we need to also see whether what is happening in the coronary artery, and then by imaging, we can know whether there is any plaque rupture, which is the cause for this kind of ischemia. So unless until we do a good imaging, sometimes it may not be possible to actually confirm the possibility that the coronaries are normal. So this is where OCT really helps us. So OCT is another good tool to actually come to a good conclusion. Having established that there are no pathology which is resulted from the coronary atherosclerotic burden, then of course we can think it. Why I'm talking about it is there could be some plaques in a individual. So the coronary disease also maybe they're associated with them. Just because they have coronary disease, that may not be responsible for this MR. In fact, other factors can actually play a role in producing this MR. Because I'll give an example. Recently, we had one lady who actually had a acute coronary syndrome, and then actually she had infarct pattern in the ECG. And then we had taken for angiogram. Angiogram shows that the territory in which MI occurred is an anterior wall, and we have a left circumflex artery showing some kind of high grade block. So then we were in a fix. What is happening? Did we mix anything with the lady which has actually caused the MIR? Was there any plaque rupture underlying a kind of a atherosclerotic plague there? So we went ahead and got done one another imaging, that is OCT. OCT shows the lady is completely clear. So now this is nothing but it is MINOCA, and definitely we can now say that to actually substantiate the diagnosis of MINOCA and what's the cause for MINOCA, whether it is myocardial or it is because of some systemic cause, whether it is because a coronary cause result from spasm or something like that. Of course, we require MRI, and which you both beautifully shown us. So I have a question for you, Deepak, because many times what happens is there could be see in Takosuba we have edema without any late gadolinium enhancement. You also can have edema, myocardioma in patients with have got myocardium, right?
Yes.
Yeah. So there's a possibility of the myocarditis. So when there is this kind of edema, what it develops, how long this edema persists? Is it up to what we say up to 2 weeks, or beyond it also?
Yes, sir. So in our experience, we have seen that the edema persists for up to almost 2 to 3 weeks, and it is rare to have edema changes beyond 4 weeks. So 3 to 4 weeks is a gray area, but beyond 4 weeks, generally we don't expect and we don't see much of edema in the cardiac myocardium. We have specific edema sequences in the cardiac MRI, specifically to look for the edema changes, and that's quite sensitive to detect minor alterations in tissue water content. So generally, like you rightly said, the first 2 weeks is very important to detect myocardial edema, and beyond that time, up to 4 weeks, it's gradually starts disappearing, and beyond 4 weeks, it's not very common to find myocardial edema after an acute event, sir.
Yet another question to both of you, Kishore and Deepak. Can you also look at what is the macrocirculation with what the available technology with MRI? Because many microvascular circulation also may be defective in some of these MINOCAs. So, for example, if you look at the microvasculature in let's say coronary emboli, microemboli, which is true in the case of plaque erosion or plaque eruption. There we can see the microvascular, which is responsible for having the ST elevations and microinfarction. So can also quantify microcirculation integrity in this.
So we can quantify the scar burden, sir. We can say how much of the scar, LV myocardium is scarred, definitely. There are
Mm.
some certain signs in cardiac MRI, which, for example, there's something called a stripe sign or an alternating enhancement sign or something. What happens in that is, in a scarred myocardium, there will be a unenhanced or non-enhancing part within the scarred myocardium, which is already enhancing. There will be a central non-enhancing stripe. This definitely signifies and is rather specific for a microvascular ischemia. So, in already a scarred myocardium, we can also conclude that there is, in addition to that, there is microvascular ischemia in already known patient. That is one pattern. In addition to that, we can overall give the what burden of scar tissue, what percentage of scar tissue is there in the entire LV myocardium. But as such, without having scar tissue, just to only diagnose microvascular obstruction, uh, at the moment, it's not very easy because there is an overlap in conditions with, like, inflammatory conditions also can cause changes in T1 and T2 values. But like we saw, parametric imaging is one aspect in cardiac MRI which is coming up in a big way, and a lot of research and work is happening that probably in the future will definitely give us some idea. And one other aspect of cardiac MRI which we didn't discuss today is called myocardial strain imaging. So myocardial strain MRI and parametric imaging put together, along with late gadolinium enhancement pattern, I think will give us much more detail and probably detect microvascular ischemia, and probably more work is required in that.
Thank you so much.
Yeah. Also, I think when we reach a stage where we have a PET MR, which is mature enough to image heart with good spatial resolution, I think that would give us many more insights about these things. It will give us a lot of metabolic information and I think a lot of the so-called hidden areas or something which is still gaps, I think some of those gaps might be filled up. Yes.
Absolutely, sir. Yes, sir.
Thank you.
Right. So I don't see any other questions from audience. All right. That's it. So once again, I would like to thank Dr. Srinivas for agreeing to spend his valuable time with us. And thank you, Srinivas. And once again, thank you, Dr. Deepak. You made it very interesting and very lucid. And I thank the management of Vijaya Diagnostic Center for giving us this opportunity. And that's it. I think we'll close the session. Thanks, everybody.
Thank you so much.
Thank you, sir. Thank you all. Thank you.